and we get started. So Sophia, please, scene is yours.
Hello, dear colleagues. I would like to present for you today this article, Adjunctive Bright Light Therapy for Bipolar Depression, a randomized, double-blind, placebo-controlled trial. It was prepared, it was posted in the American Journal of Psychiatry in 2018, and its impact factor of its journal was at that year 13 and 16, more than 13. And so it's pretty good.
Софья, прости, пожалуйста, перебью тебя. Я проверила, у нас все вроде бы замьютены, кроме тебя. Ну и сейчас меня, потому что я говорю, у тебя, может быть, какие-то там есть, что-то ты делаешь с компьютером, потому что какой-то шум создается. Нет?
Да, есть помехи немножко, когда ты говоришь.
I don't know.
В общем, постарайся, это, может быть, не трогать лишний раз компьютера. Аккуратно, потому что шум, конечно, очень так меняет восприятие. Спасибо.
Честно, даже не предполагаю, где здесь находится микрофон, чтобы его не касаться.
Окей. Ну, сейчас все вроде хорошо.
Все отлично. And so, let me put your some main points about bipolar disorder. Bipolar disorder. Bipolar disorders are characterized by episodes of mania and depression, which may alternate. Also, many patients have a predominance of one or another, and therefore, exact cause is unknown, but heredity, changes in the level of brain neurotransmitters, and psychosocial factors may be involved. Diagnosis is based on history and maybe using some tests. It's a quite strong disorder because it is one of the leading causes of disability worldwide and is associated with high rates of premature mortality from both suicide and medical comorbidities. And we should know that bipolar disorder divides into two types, and they are just two different nosologies. Bipolar disorder first type, that is bipolar disorder was the first type that has episodes of mania with strong symptoms of hyperactivity and just very, very active patients yes. And bipolar second type, that they didn't demonstrate extremely strong mania, just hypomania, and more times they have just depressive symptoms. What depends to bright light therapy? Everybody, I think so, everybody knows about melatonin, that this is a neurohormone that is synthesized in several ocular in our pineal gland, and its secretion is regulated by bright that involves on melanoxin in our eyes. And we should say that that's bright, its length is about 50 nanometers, but no more. And so that's why we use yellow screens in the evening on our smartphone, because this type of waves, they are not so strong. They don't have so strong involvedness on our melatonin secretion. And so bright light therapy It's just using or lamps or something like glasses. They name glasses, but they're not them at their nature. And this is some subjects that brights very, very light, bright light about for 4,000 to 7,000 lux. And it can be, we can use it for therapy, some circadian disorders or some sleep disorders. And sometimes in bipolar disorder, its nature is not only serotonin nature and pathogenesis. There are some ideas that melatonin is also involved in pathogenesis of depression disorder, bipolar disorders, and so maybe bright light therapy may be useful. Patients with bipolar disorder are susceptible to the environmental cues that alter circadian rhythms and trigger relapse. And so depressed bipolar patients frequently have delayed sleep phase and atypical features, which are predictors of light therapy response. And also it's mentioned that there are a lot of research, there are a lot of studies that use the bright light therapy in treatment of bipolar disorders. But in these studies, there are about a lot of these studies, and they have different regimens of light therapy. Some at first, it was thought that maybe it will be useful just morning therapy, like in our natural circadian rhythm, that when we get up, we go out and sun shine, and so our melatonin secretion is inhibited. But later, we found more evidence, and for midday and even evening light therapy using. And so the authors, they had some hypotheses that the remission rate would be higher and the mean depression score will be lower in the white light group compared with placebo group if they will use midday therapy of bright light. And they performed a 6-week randomized double-blind placebo-controlled trial to investigate the efficacy of bright light therapy at midday for bipolar depression. What about study design? It's about participants. In the end, sorry. At the end, a number of participants was 46, and that was the participants that were perfect by inclusion criteria. And what were inclusion criteria? Patients about from 18 to 75 years old with bipolar 1 or 2 disorder. They had to have moderate or severe episode of major depression, a score more than 20 on the PSI-ADS. And also they had to know who didn't have pneumonia and mixed symptoms. So they they may have them on their anamnesis because it's a bipolar disorder, but not at the same moment. And also they the eligible therapy was anti-manic medication at stable dosages for at least 4 weeks. But we should say that also they used a little bit strange classification that because they used also both mood stabilizers and antipsychotic drugs that are that they have different pharmacological effects. And also it was, if applicable, patients can be treated by adjunctive antidepressant medication at stable dosages for at least 8 weeks, and low dose sleep aids for mild insomnia, just like zolpidem and benzodiazepines in small dosages. And what about exclusion criteria? Exclusion criteria were patients who had any manic, hypomanic, or mixed episodes in the past 6 months, rapid cycling in the past year, active suicidal ideation or attempted suicide, acute or chronic psychosis, obsessive compulsive disorder, uncontrolled thyroid disease, any substance use disorders in the past 6 months, or a positive urine drug screen. And as exclusion criteria for bright light therapy, chronic eye diseases or treatment with photosensitizing drugs. Study design. Patients were divided in 2 groups for bright light therapy. Just first group was active treatment group, and they used 7,000 lux bright white light, and placebo group with 50 lux dim red light. Why we're choosing those lights? As I said, melatonin secretion is inhibited by a short wave light, but red light is a long wave light, and so it hasn't so involvement for circadian rhythms. And in other clinical trials with bright light therapy, also was used 50 lux dim red lights like a placebo. And the randomization for antidepressant use was performed with a block randomization design in about 6 patients per block. At first visit, it was eligibility visit. Patients came to the laboratory and they passed a lot of tests for depression, for anxiety, for sleep quality, for seasonal effectiveness, for morning evening scale, and others. Then they got their devices for bright light therapy. The devices were the same at their look, and patients they didn't know what type of light is useful and what is no, and they said that they won't Google it. And so they really didn't know, do they have placebo or active treatment. Weekly visits were performed for assessment of mood level, side effects, suicidality, sleep quality, and psychosocial function. And after every weekly visit, duration of light therapy was increased by 15 minutes until duration of light therapy was attained 60 minutes. And then about after 6 weeks, study was ended. And
Sophia, I have a question. Do you think that the blinding was done, how to say, like inappropriate way? Do you believe that they can achieve this like perfect blinding when patient don't know like what group they was randomized in which group? Do you have any concern about this like blinding?
I want to
Or
believe.
if anyone have answer for this, it will be great if you can discuss some arguments, like why you think it was inappropriate, like then blinding was appropriate or not appropriate.
I think that blinding was appropriate as much as it's possible, because it's quite hard to don't rest. No, I think that average person, not medical student, not I don't know, doctor, not maybe physics, they or biologist, they don't know about this light features, and they almost always does know something about that. Maximum that they can know that light inhibits melatonin secretion, but they don't know that it differs from its color. And so I think maybe it's something about it's a question about a compliance between patient and researcher, because I don't know. I hope that patients didn't lie about that. Do they know or don't? So that's all that we can do.
Okay, yeah. Okay, let's return to this question a little bit like later.
Yeah.
And let's talk about blinding. So what type of blinding was in this study?
And the second type of blinding, it was double blinded, because both personnel, they didn't know, and the patients too. Personnel conducting the visit and performing the clinical ratings were blind to the treatment, and even researchers, they didn't contact with patients when they got their devices. It was for instructing people. It was other special laborant, other person, and they gave them these devices, but not researchers. So researchers didn't know what type of light is performed for their patients. So it was double-blind.
Does anyone agree with this sentence that it was double-blind, or anyone has other suggestions? Mikhail, what do you think?
Hello. I think that this is enough correct blinding procedure, and we can assume that this could understood as double-blind procedure, I think.
Okay.
But there was a big problem because of this is not quite this is not fully blinded procedure, because patients can know the real group in which they are because of the nature of treatment is physically physically understanding. So we cannot pack up red light in white light, and vice versa. So this is not a fully blinded procedure, but if we decide that patients did not Google any features of light treatment, if we I think that they are compliant with this statement, so it could be assumed as blind procedure, but it's not fully blind for me.
Okay, I think that I should explain my two questions about blinding. Like, first of all, I think I don't see this is any sentence about like about exclusion criteria that sorry that they that the participant have no experience of this like therapy before. I mean, if you use it once, you probably know how it looks, and probably you know if you get placebo. So I think this is like one of my major concern about blinding. And second, about what is the type of the blinding, I would say that it's probably not double, but at least like on 3 level it was blinded. Also, they say that not only personnel and who work with participant was blinded, but also statisticians who doing analysis. And I think this is like a little bit like a higher level of blinding. So I just think that they not really correctly put this blinding name in the name of the research. So it should be like triple blind study from like
So
from my perspective.
this is not double blind and not triple blind. It's something other kind of blinding.
Yeah, it's четвертичное ослепление. Yeah.
Quartered blind.
Okay.
Okay, let's go. Yes, this is our checkpoint. If you have any questions, maybe others, not Marina and Mikhail. No? Okay.
Sophia, how you overly rate this like study design? Do you feel that study design matched study question?
Study design is not perfect, not ideal, of course, but
Why?
on the first wise, it looks pretty good. Of course, because of questions about blinding, and also because of treatment therapy. Because it's cool that the eligibility inclusion criteria was that this therapy has to be long. Just let me remember, it's 4 weeks for antimanic medications and 8 weeks for antidepressant medications, so that we can say that this the potential effects that we can see, they will be not because of therapy. But from the other side, antimanic medication, as we can see later, they have some strange classification, and they also included in antimanic medication antipsychotic drugs that have antidepressant effects. And so we can't be confident that our effects will be just only because of therapy, bright light therapy, because of course antimanic medications in that type, they can also involve. And so it's a little bit strange. And also I had it was just one question for me. It's a citation. Patients with worsening depression, severe suicidal ideation, or emergent hypomania were evaluated by the principal investigator and non-blind monitor, and appropriate clinical management was provided. And for me, it's a question, will be these patients included in this research, or just they were dropped out, and that's all. And maybe if we include them, our results will be others.
I can explain why they point out and add this sentence. It's kind of very classical strategy for severe adverse effect or events. Like if someone, like for example, suicidal ideation, like especially severe intensity.
Of course. So it's a kind of security. I understand, but.
This is the census is not really do something with efficiency, but it's like about like safety, how they handle the safety protocol, and it's a kind of classical scenario when PI, of course, they should know about any severe adverse event in like 24 hours after this onset, and should evaluate it and to make the decision how to handle it. Should we hospitalize a patient who have these severe events, or what to do with it? So it's about organizational question, what to do in serious case, and principal investigator as a responsible person for this, how to manage it. And especially it's very important to do this in blind way, because in non-blind way, because it's sometimes we should, for example, just say that, okay, we don't need, we should just interrupt the treatment, and if you blinded, you couldn't say that, okay, like we probably right now stop the active or inactive, like placebo treatment, right? So you should be unblinded to make this decision. So it's like if it's placebo and we have some severe events, so you probably there is no sense to like stop medication. But if it's not placebo, we can actually do something about this. Is it clear why they do this and why it's not really make any effect on blinding process?
Yeah.
Okay.
I agree with Sophia with this question, because this is the question not for blinding process, but the question for analyzing results. We don't know how they utilize the results of these patients who had worsening of depression, and from this sentence we can think that they changed the main treatment of these patients, pharmacological treatment, and we don't know whether their results were used for statistical analysis or not, and authors didn't understand this question.
No, it's not the case here. Like, I mean, they just put here how they handle these like severe adverse event. It's not about analyzing. This person, they monitor, and it's always some managers who are doing like quality assessment. They have nothing about data and about analyzing data. This person as like monitor or principal investigator, they should be responsible for safe conducting trial, and it's not about like they like principal investigator, they see the result like in tables, they don't see the results like for individuals. When
yes, the question is were these results for patients who were changed in treatment during the study was analyzed as other results or not? Flowchart of patients who were changed treatment, who were withdrawn for any reasons. We don't understand how they managed their results. Were they analyzed or not?
How it's related to the sentence which is quoted here? I mean, we discussed this sentence about like non-blind monitor. So you point out the different one. It's about like how it was also like your question on previous journal club when we discussed about how we can be sure that someone not interrupt their treatment. And this is other, like it's the question of adherence, I think, and how
not only adherence. They
and what do you mean about change? Like what is the change of the
appropriate clinical management? Clinical management for me is appropriate pharmacological treatment as well. So maybe they changed their treatment or not. I don't understand.
I also don't understand your concern. Like, what is sentence in the article, or you don't see any sentence in the article which can answer your question? What is the problem here? You concerned about some sentence in the article, or that it's not explanation of some important strategy during the trial?
From this sentence, we can think that some patients had worsening of depression or not had. We don't know were they patients or not. And in this case, these patients who had worsening of depression received appropriate clinical management. And this clinical management can assume different treatment, pharmacological treatment. And I don't understand, were there any differences in pharmacological treatment for this subgroup of, I don't know what group patient?
Okay, so your question is, if person have like worsened symptoms like depression, and usually if someone feel like worse during the trial, they can change their intervention, right? And to add something like some medication to be sure that person's safe and symptoms was treated as
with pharmacological agents, yes. And this sentence, appropriate clinical management, for me, means that they could receive different kind of pharmacological treatment from the time that they worsened their depression.
Yeah, okay. I think your question is more about like results and how they presented. And let's move to like this part, because like it's right now I would like to mostly point out about like study design, how they conduct their like how they seen of how to say, like how they conduct actually the trial, and how they handle with like some anticipated problems, and we see it here. And but your point is like truly makes sense, and we should, like when we go in and see results section, we should be very careful and see how they report about an adjunctive treatment, how many person receive adjunctive treatment, and do this patient with adjunctive treatment were subanalyzing or not, because like it's really important. But let's see what does the results say us about it. Thank you. For study design, is anyone have other questions, just to be sure that everyone have time for raise some concerns? Okay, Sophia, I think we're ready for results.
And so, what about the outcome measures? There were two types. The primary outcome measures were the rate of remission, defined as PSI-X score lower than 8 within the week of 4 to 6 period at the continuous PSI-X course at the endpoint visit. And the secondary outcome measures included the rate of response, the proportion with reduction more than 50% on PSI-X score, frequency of mood polarity switch, and so on and so forth. You can read it. And also we can say that investigators, they thought that both patients who were still actively enrolled at weeks 4 to 6 had fully completed their dose titration protocol, and those who withdrew earlier, they both were assumed to provide informative outcome data, and just like this. And so, what about the results? They had 93 potential participants with agreements.
Sophia, do you have consort diagram on your slides? Because usually we start with this one,
Just like
like
this?
when we describe study. No, the consort diagram, which was in supplement.
No, sorry, but
Okay, I added in Telegram channel,
yeah,
and you can also look at this, because I think it's really important to see how, like, how many patients they screened, how was included in the study, because it really give you some sense about the recruitment process and how they like sampling their sample. Do you
yeah,
do you see this consort diagram? How many
Yeah.
patients was screened at the beginning?
It was screened more than 1,047,
Mm-hmm.
and 1,001 were excluded, and the last 93.
Yeah, so it
they
was
got-
pretty big sample size, like at the beginning. So they do a lot of like screening work here,
Yeah, of
and
course.
just see how little, like, what is the how narrow this like sample at the end, like from more than 1,000 to 46. So it just give you some notice about how these results can be generable to this population with depression, right? Like it's kind of like it just show you that this specific like inclusion and exclusion criteria, they are very they're very narrow, and like if you find this, like even if you find the effect in this clinical trial, it's probably shouldn't be generalized to like all population of like depressive patient with depressive symptoms, right? So it's kind of very unique participants with very unique inclusion and exclusion criteria. So that's why consort diagram is very, very important. And next time it's a recommendation for everyone, just like if it's if a researcher did it for you, use it, and it's give us a lot of sense about how this process go on. Okay, thank you, Sophia.
Yeah, and so these 46 participants, they were divided into two groups, 23 and 23, comparatively. And so what we have to pay in our attention, the 2/3 of eligible patients.
Sorry, why very important? Like you said, 23 and 23. Like usually at this moment, people start to ask questions. So does anyone have some question, like why they choose these strange numbers? Or Sophia, can you explain us why 23?
I think because it's a half of 46, and 46, it's because only 46 participants were perfect for exclusion and inclusion criteria.
Okay, is anyone have other option how to answer?
Those two groups that are divided for active red light treatment and dim red light, and not treatment, just pharmacological.
Yeah, like when you see 23 per group, like your question should be why so little, right? Like
yeah, of course, but as you said, that it's because of a very strict criteria, and I think
not only. I mean, like you can still do screening and just like screen more and more, and like during the time you usually include so many patients as you need based on not what you have right now, but based on the sorry.
One more moment about 23. At first, researchers, they founded a power of the
exactly.
study.
Yeah, this is what I want you
Yeah,
to
yeah.
talk more.
And
Okay.
at first they wanted two groups and about 30 patients in each group, and at all 60 participants. But unfortunately, their funding money, they end, and that's because this study was stopped, and they stayed in 23 patients in each group. That's not any statistics or some, I don't know, other sites, just financial.
Yeah, I mean, it was some statistical behind of sample calculation, but during the study, it was something happened, and money was go away, and that's why they have so little participant. And usually, when you do like any statistical analysis, at least you should have 30. So it's kind of like minimum. It's like classical minimum which you should have in your group. So this like magic number which you should like keep in mind like always. And when you see someone tell you about the study which include less than 30, sorry, you should also keep in mind that something wrong, probably can wrong here. But they do a lot of work, like they do calculation, sample size calculation. Don't spend a lot of time on this, but it's I just want to everyone keep in mind on this because it's like critically important. Yeah. Okay, let's.
Yeah, and one more important point is that we think is that 2/3 of eligible patients had bipolar 1 first type disorder, and for me it's maybe I should say it in discussions, but I want to say it and now both now and in discussions that bipolar first type and second type disorders they are quite different, and if they used both types in this research, maybe it will be better that if they calculate also for each type disorder different calculations, different analysis, but they didn't do this. Okay, about good. 45 patients attended one or more post-baseline visits, and 40 patients completed the study. About that 6 that didn't complete, almost at all times, it was because of non-medical factors, just like some of them they couldn't wear these glasses on their workplace, and so they had to withdraw this study. The maximum dose of light therapy exposure and the actual light dose per daily session reported by the patient at the endpoint visit did not differ significantly between groups. And also the median number of post-baseline visits for the active treatment group differed significantly between groups, and the early withdrawal rate did not differ significantly between groups. And that's, as I said, that's one is pretty strange.
Okay, you feel it strange and you pointed out here like twice already. So let's discuss about why do you think it's problematic and why do you think it can impact on interpretation of results? In which direction? Like if we have like more bipolar type number one, how you interpret your results? Like what does it mean for results? Because this is important.
What does it mean for results? That means that bipolar 1 disorder, it's more contrast, and for this type of disorder is more characterized with more fast recycling. Of course, they had an exclusion criteria that rapid cycling of the disease between depressive and manic stages, but it may be just like a spontaneous remission, not because of light therapy, but just because it's time for remission for bipolar 1 disorder, because it has more quickly flow, it flows more quickly, and that's why if in one group will be more patients with bipolar 1 disorder, and if it will be a group, for example, if it will be a group of active treatment, and as we can see, it's like this, yeah, and so we can have false positive results.
Agree.
And about medications, as I said, that they have some a little bit strange classifications, that antipsychotic, they included them in mood stabilizers, and so we don't know what's effect was in the active treatment group, antipsychotic drugs or light bright therapy. And one more question to prevent questions about seasons. They, yeah, of course, they administered in what season the study was proven, and it's quite, I don't know, they didn't analyze it at all, just they written it in tables, and that's all. And I think that maybe they should analyze this too, because for bipolar disorder, for depressive episodes, is it's characters for seasonal dismissions, for seasonal worsening, especially on autumns, fall, and winter. In conclusion, that's the results that the active treatment group compared with the inactive treatment group had a significantly higher remission rate at weeks 4 to 6, a lower mean depression score at the endpoint visit, significantly less excessive sleep, and less, less trouble concentrating, no, it's not statistically. I forgot the word.
Significant?
Yeah, it wasn't significant. I made a mistake when written it. And also, I don't know why they written a very big number of points that like they had better mood, that they had better sleep quality, but all these results weren't significant. But they mentioned it in the article. They can. Why no? And different questions about.
Actually, maybe if you ask this question, probably you would like to receive some answers from people. Like maybe other people have some ideas why they include non-significant results in their paper.
Maybe I think just maybe that about because they did that tests, and so they have to post its results too. And maybe for light bright therapy, how to say, sometimes we have a lot of dreams about light bright therapy, and maybe they wanted to, I don't know, to point it even it's insignificant, just a little bit better, and so they pointed it, maybe because they believe in this method.
Usually, when you plan the analysis, you should list primary and secondary outcome. And they do a lot of work of thinking about like why this treatment, like white light treatment, can be beneficial. And it can be beneficial for depression, right? And can be beneficial for sleep. So that's why they try to play with like different variables to see maybe something will works. And usually it's limitation when people do a lot of analysis, because if you do multiple analysis, you will find something. So, and usually it's not really good. So you should be very specific, and to really when you're thinking about outcomes, you really should thinking a lot about why do I think like this outcome is appropriate and why it's important clinically for patients. So, and from my perspective, it's important to first of all choose outcomes, and secondly, just based on the outcome which you choose, to present this in results. Doesn't matter it's significant or not. If you choose it, you should present it. If you don't present your negative results, it lead to what? To which kind of bias? To publication bias. When we see a lot of positive results, because people who have negative results, they tend to not present their data, because okay, I have like negative results, why I should publish? It's a kind of wrong, it's a misconception. Everything like you should write on your paper and present. It's we shouldn't be like thinking about, oh, it's not significant, it doesn't important. No, we should also carefully thinking about like why it's not significant, why it's I just would like to point it out here, and you thinking about this a little bit more, that if you see like p less than 0.5, it's not the miracle. You also should notice every results which you see there, and carefully looking on them. Yeah, this is just like what I think it's can be important to notice. So why you put out in conclusion the results? What is the idea here? Like usually conclusion is like your main like direction for future studies, or like yeah, what I see here, it's results like mainly, and figure like what is the idea? Yeah. What is do you have any more slides for this one?
The conclusion, no.
This is last slide.
Oh, discussion.
Okay.
Yeah.
Okay, let's start with your plan.
About positive moments of this study, I like just this strict in and exclusion criteria.
Why it's important? Why it's important? Why it's important to have strict, clear inclusion and exclusion criteria? Why it's important?
Because if we won't have this criteria, we will have quite heterogeneity in study in patients, and so it will be very difficult to analyze it, and it may be our results may be false positive or false negative, not because of our active treatment, but because of some not excluded in the start.
Yeah, exactly. Yeah, right. Like and, if you yeah, it's you add inclusion and exclusion criteria mainly for like to restrict your sample size, like your sample population, to restrict it and to make it less how to say, like less variability between patients in terms make it like more similar to each other, because there are so many things like which make us different from each other. So it's better to control for at least like diagnosis, like treatment and other things which they put in inclusion and exclusion criteria. So it's just to control variability your sample.
Yeah, and talking about variability, we should say that patients with antidepressant therapy, even we had patients with antidepressant therapy, and we had patients only with mood disorder therapy, and I like that patients with antidepressant therapy were represented into both groups and in equal parts, and so it was.
By the way, why it was represented in both groups?
Because of randomization. And
they put it as a randomization variable. So they stratified. So it's like intention to do this like based on antidepressant therapy. It's not just like yeah.
And moreover, it was good that they published that they counted power analysis, but unfortunately, after that they wrote that they didn't got 30 patients as they planned, and after that it will be negative. That after that they didn't write anything about recalculating of power of analysis, or no, they didn't write anything. Just we don't know what happened because of a lack of 7 participants in each group. And so negative part is that small number of participants. And also we should pay attention that active and inactive treatment groups differ significantly on baseline on depression and functioning. They had different points from their their scale. And also that there is no evidence about differences in response between the patients with bipolar disorder first type and second type. They didn't analyze it at all. And patients with bipolar disorder 1 and 2, they maybe they should just do like with antidepressant therapy. They just include it in randomization criteria, and then they will be, these patients will be represented into both groups in equal parts, and it won't be negative side.
I think it would be problematic to do this.
Maybe, or maybe it will. Maybe they should just because about 31 from 46 patients had bipolar disorder first type, and so maybe bipolar disorder second type just had to be like an exclusion criteria. Maybe it will be more simple in that time, or about.
Yeah, and also it can be problematic because if you want to stratify your participant based on more variables, not just like sex or treatment, like placebo versus intervention, or like here it's based on antidepressant therapy. And actually for me, it's still a question how they randomize the group based on antidepressant therapy. So how many groups was there? So okay,
there were 3 types of antidepressant therapy, and so it were 6 groups.
Yeah, but in table 2, I see this is like 4 types of antidepressant. So they say it's like more than one, SSRI or MAO inhibitor or bupropion. So I don't really see like, or maybe I miss it, like why 3 antidepressant option?
No, maybe more than one.
because they say that they have like 6 participants in each block. So that's why if you
they didn't pay attention for groups that had more than one antidepressant. Only SSRI, MAO inhibitor, and bupropion.
Why do you think so? Why make you think so?
I don't remember.
Why do you think they don't involve
They didn't
bupropion?
describe this at all.
They don't say about this.
No, nothing.
So it's just like you randomly pick one and say that, oh, they probably don't do this. Okay. So, and it's like why they don't randomize, like put in randomization, like if you put a lot of variables in your randomization, you just simply couldn't be sure that randomization will work, and it will be like matched groups, because there are like you should have like more and more participants with when you adding more variables in randomization process. So usually it's like people use like one variable which is like truly important. And I think like you have like very good like idea about that. Probably the effect of this therapy can be explained just because the diagnosis and it's like and we see these results even if we don't have therapy. So I don't really know, and especially because we have like so small sample size, it's really hard to say it's like with evidence, because like also you kind of speculate on this as well, because they was balanced like in placebo group and in treatment group. It was same number, like same percent of patient with bipolar 1 or 2. So it's if we say okay, like this is result just explain of the type of the bipolar, why we don't see these results in placebo group? Why we don't see the same results in placebo group if it's explained just the diagnosis? Do you see what
Yes, I remember that it were not equal representation of patients with bipolar 1 and 2 in different groups, like 13 and 10. And
I mean, it wasn't no, I mean like it wasn't like differ. Like when they do statistical like tests, it wasn't statistically different between this. Like we see that like this is like 60%, this is like 80%, but there is still, it's not it's again, this is like problematic of problems which related to the number, like small number. But they like here, like this proportion is like okay, it's not the same, but it's quite similar. And especially like you will see that in placebo group the bipolar type number 1 is like 80%, so it's like more people there. So if you say that it's just spontaneous remission, so why in placebo group we don't see this effect? We should see like more people in remission there. Placebo, based on your argument.
It's just a potential argument because nobody knows when remission will start, and so if it didn't happen in this study, that don't mean that it won't happen in I don't know, or in other study, or in all research. And so it maybe that's all.
All research have different level of uncertainty, and we know that like we could be uncertain like in a lot of things in our research. And the reason why people do research is not just like to be like okay, I'm confident with this. Like every research is like some degree of confidence, and we just like tend to would like to have like high degree of confidentiality, and we just don't it's okay that you like don't pretty sure, like, but we should thinking like critically about, okay, like from this little information which we have, like what we can conclude. So this is the main ability of our
Yeah.
research. Okay.
And just no. Yeah, or two more questions. No, at first I should tell about that there is no information about other light sources such as gadgets and daylight exposure, and it's maybe it's not so strict and not so moderate negative minus, but maybe it will be good if participants just pointed in their they pointed using of the light bright therapy in some like diaries, and maybe it will be useful that if they also pointed information about gadgets and daylight, because the inclusion criteria was from 18 to 75. Younger people, they use a lot of blue screens, and they use them almost all of the day, not only day, also and morning and evening and even nights. And so I think that exposure of blue light will be different to this young man with a smartphone and to, I don't know, elderly person who use something with bottoms to call. No, this just like so simple example, and for me it's a pity that they didn't point it this part of life, and also as a daylight, because maybe if participants were from one city, maybe it will be not so important, but at the same time we can have in population in these participants both people with shift work and I don't know, people just office workers that are placed in buildings almost at all of time when sun shines, and so they didn't get daylight at all. And it will be good if they pointed it, because it's important, as for me, of course. And two more questions that I pointed about 15 minutes before our meeting, that why were differences in antipsychotic therapy not considered? As I said, that they included to antipsychotic therapy also mood stabilizers and antipsychotics with antidepressant effect, and they didn't analyze it at all. And how was the statistical analysis of dropout carried out? And maybe because they said that only 40 patients they followed study to the end, and so that 6 they had only several weekly meetings, and there is no evidence about how did was it proven in statistical analysis. It's
Sophia, let's start with your first question.
okay.
Why were differences in antipsychotic therapy not considered?
Yeah.
Where's do you think in this, like, can you explain a little bit more about like
was the difference between groups in antipsychotic therapy?
Maybe I wrote not very clear. I say not antipsychotic, anti-manic therapy. Usually, anti-manic therapy is mood stabilizers. They don't have antidepressant effects, and so they couldn't involve the results. But in this study, in anti-manic therapy was not only mood stabilizers. I can find this table. Yeah. Oh, no. That's also antipsychotic, lithium, and anticonvulsant. And so antipsychotics, they have antidepressant effects. And we don't know what kinds of antipsychotic they use. And we don't know just how it could involve to the results. So
Okay, so like if you do statistical analysis, you just like what is your like if you can give some advice to researchers how to handle with data, as I understand, you just like your suggestion is just give to include this as a variable, right?
Or include this as a variable, yeah, or not include patients with antipsychotic therapy.
Yeah, but it's kind of okay. I see your point, but it still make me concerned also about like how you recruit the patient with this kind of diagnosis, and like it's not like the preclinical study, which you have like when you have animal and you control everything. This is like real people with real like mental health issues, and sometimes it's really hard to.
Yeah, I understand it. So they just didn't write anything about this, and it wasn't right because they should at least tell about what type of antipsychotics they used and did they have antidepressant effect or no.
Yeah, it's clear. Okay.
About second. If you have other questions, I'm all. If you wanna answer some or ask me something, I will try to answer you.
Okay, let's continue with second one. Like, how was the statistical analysis of dropout carried out? And can you explain a little bit how many patient was in like how many was dropout in what group?
Just 1 second. At all, dropout 6 patients. Just no, it was first maybe. Yeah, for only 40 patients completed the study at all, and so it was something about equal for both groups. But
can you
yes, I
not,
wanna find.
This is table 3. It's there. Okay, this is actually we a little bit run out of our time, and I think we should probably stop right now and ask people if they left some questions, and to try to answer to them. Okay?
Yeah.
People, your turn. Okay, looks like no one wants to add some question. Okay, so we can discuss a little bit about dropout. So if you look on table 3, this is a dropout rate there, and it's clear said that in active treatment, it's only 1 person. In placebo treatment, it's 5 dropouts. So it's clear that like in placebo treatment, even if they don't find statistical significance, like P more than 0.005, it's still we see that it's clear that in treatment, like in treatment, the patient was more adherent to this, and they less likely to withdraw their consent.
Yeah.
So that's why your question is like, why don't put this in analysis? It kind of makes sense.
They put them in analysis, or this they put their results in analysis, but they didn't say anything about do they make some поправок.
Adjustment. No, this is what I tried to say as well. Yeah. But what do you expect? Like, why, if they included, what do you expect to see?
It's a good question.
Like, do you feel? So this is why it's important. Like, you shouldn't just say like, oh, I see this, so they don't do this. You should keep in mind like why it's really important for your particular study, why it's important for your specific interpretation of results, not just like, okay, I know that this bad, so it's bad in this study. It's not really, I don't feel that it's problematic here, honestly. It's only 6%. And actually, I see that in table 3, they made mistake. They say that it's like 19%, but actually 7 of 46 patients, it's 13%, not 19. So they also do some calculational errors there.
Yeah. How it could involve because if patients withdraw, it may be from the one side, it may be because of their improvement. No, that's, as we said, that's because it's time to remission and they felt better, and so they could stop the treatment just because they didn't need it. And so in this time we could have more positive results in placebo group, but we don't have them because these patients, they just withdrew the study. It's this from the one side. From the other side,
remember I asked you a question about blinding at the beginning.
Yeah.
So, and I feel that sometimes when you see that in placebo group, people become more and more likely to withdraw consent, it's more, it just like can be the sign that probably they know that they get a placebo and they're not interested to participate in the study anymore. So that's why I feel that blinding probably was not work very well, probably. So this is just like my guess, but just to see that 1 person withdrawal inactive and 5 in inactive in the group of 23, I feel that it's kind of tell you something, right?
Yeah, of course.
Okay, I think we are ready to finalize our meeting. I'm really glad that everyone can join us, and I don't know, like why people use so not active in discussion. В чем проблема? Не знаю.
Окей, я заканчиваю рекординг. Так,